Good day to all the participants of this adult immunization series. For today, we will be focusing on tetanus as a vaccine-preventable disease. This lecture is prepared by Dr. Rosalie P. Zabora and delivered by yours truly, Dr. Roselle Jade Javier. So this lecture is intended for specialists, general practitioners, and allied health professionals in general. The evidence summaries that are to be presented are based on the best available scientific evidence at the time of formulation of the guidelines. There are, however, some limitations in some aspects of screening the information. So the summary or the recommendations that we are to be presenting is based on a systematic synthesis of evidence to address immunization practices. This is based on an appraisal of best available evidence on 8 identified clinical questions. They have followed widely accepted grade approach, evidence to detection framework criteria. The following recommendations shall hold indefinitely and will be updated after 3 years or when new evidence becomes available. So this is just how the information was appraised. This is the basis for assessment of the quality of evidence using the grade approach. So the certainty of evidence ranged from high, moderate, low to very low based on the confidence of the panel to say that the true effect lies close to that of the estimate of the effect. Now, it becomes lower, the quality of evidence becomes lower based on some factors, and these are risk of bias, important inconsistency of results, some uncertainty about directness, high probability of reporting bias, sparse data or imprecision, and publication bias. So let's jump into tetanus as a vaccine-preventable disease. This is the summary of recommendations as of present for tetanus. So it's based on one important question: should tetanus vaccine be recommended to apparently healthy individuals? So first, among healthy adults who completed the primary series, we recommend giving any tetanus toxoid containing vaccine every 10 years. However, for those with unknown status or incomplete series, we suggest giving a primary series that includes Tdap, or tetanus, diphtheria, and acellular pertussis vaccine, followed by any tetanus toxoid containing vaccine. So let's first clarify what a complete primary series is. So it is usually given for 3 doses. The interval between the first and second dose would be at least 4 weeks, and the interval between the second and third dose will be 6 months. So it's a 0-1-6 schedule. Now, for the pregnant population, which is also a main focus for tetanus immunization in the country, among pregnant women who completed the primary series, we suggest giving any tetanus toxoid containing vaccine during each pregnancy. But for those pregnant people with unknown status or incomplete series, we suggest giving a primary series with Tdap, followed by any tetanus toxoid containing vaccine. But if you can see, the certainty of evidence ranged from low to very low. But despite this, the panel was unanimous in recommending the vaccine to the said population. Why is this so? Because they found that the burden of tetanus is still significant despite achieving the maternal and neonatal tetanus elimination status in 2017, and because of the high case fatality rate that is brought about by tetanus infection. So if you would notice, if you go back one slide, among healthy adults, even with complete primary series, every 10-year immunization is still a strong recommendation. They also found that there is a lack of local non-neonatal tetanus surveillance system, and studies included are those who were able to complete the primary series. So there really is some lack of information on tetanus immunization in general. Some things to consider about tetanus immunization. Frequent administration of vaccine does not provide added benefits. So it's still best to follow the recommended schedule for each dose. The vaccine is more reactogenic if it is administered closely rather than with long intervals. And all but one panelist agreed with the dosing specified for the pregnant population. Why is this so? The panelist who was against it cited that health centers currently follow the recommendation from the World Health Organization, whereby subsequent pregnancies will no longer need tetanus immunization once a total of 5 doses have been administered. So later on, we'll be tackling on more information about that. So let's first have a review on what tetanus is. Tetanus infection is brought about by the organism Clostridium tetani. This is an obligate anaerobe organism. It is a gram-positive spore-forming rod-shaped bacterium that is usually or more commonly found in soil. The most common portal of entry is through broken skin. Even some minor abrasions can be a risk factor for tetanus infection. So the Clostridium tetani produces a toxin known as tetanus spasmin. And this tetanus spasmin is a neurotoxin that binds to presynaptic membranes at the neuromuscular junctions and undergoes retrograde transport to produce the clinical effect. So how does this come about? When spores enter through broken skin, the tetanus spasmin is produced and therefore is able to bind to presynaptic neuromuscular junctions. After this, there is an uptake of the toxin, the tetanus spasmin, by the presynaptic inhibitory neurons, which leads to the inhibition of the release of inhibitory neurotransmitters. So the inhibitory neurotransmitters are inhibited, essentially, and this leads to the clinical presentation of tetanus infection, like your muscle spasms, unregulated muscle spasms, trismus, dysphagia, and even autonomic nervous system disturbances, leading to hyper or hypotension, tachy or bradycardia, bladder, and bowel dysfunction. So let's go deeper into the burden of disease. Why is it important to know or emphasize the importance of immunization? So in 2019, there have been reported around 34,683 cases of tetanus infection worldwide. So this is worldwide. But in the Philippines, in the same year, only 78 cases of neonatal tetanus was reported, and only 953 cases of non-neonatal tetanus were recorded. So this obviously shows a lack of non-neonatal tetanus surveillance system in the country, which could make the possibility of underreporting very likely. Data also on long-term outcomes of these tetanus infection patients is also lacking, because usually the cases happen in low to middle income countries where there is a lack of surveillance system for the disease. Our Department of Health reported 15 cases of clinically confirmed neonatal tetanus at around January to April 2019. Among these 15 patients, 8 or 53% were unvaccinated mothers. 4 or 27% were mothers with unknown vaccination status, and 1 or 6% received only 1 dose of tetanus diphtheria containing vaccine. So this is quite a significant information, because this further highlights the potential of tetanus immunization to prevent these cases. Also, to further highlight the impact of tetanus infection, this, or tetanus disease, this leads to 0.027 years of healthy life lost due to disability per 100,000 individuals. Further on, it also leads to 26 years of life lost per 100,000, and also 26 disability adjusted life years per 100,000. If you go look at this number, this may seem small, but it further magnifies if you think about the prevention that we can do, because this is really a preventable disease. So this should be basically zero. So now we go to benefits and harms. So the data that I'll be presenting in the next slides is based on evidence that has been taken from a total of 8 studies. The population in these studies range from 18 to 64-year-old individuals. 3 were randomized controlled trials. 2 used tetanus toxoid vaccine. 1 study used reduced diphtheria toxoid vaccine, and 5 used TD reduced diphtheria toxoid and acellular pertussis vaccine. All the vaccines contain the same amount of tetanus toxoid, 20 international units. However, there were no available studies comparing tetanus toxoid vaccine against placebo. Right. So this is just a table summarizing the benefits and harms of tetanus vaccine among healthy adults. And we'll go through it one by one, briefly. But there were no studies that investigated on the incidence of tetanus and all-cause mortality. 7 studies investigated on hospitalization as an outcome after tetanus immunization. However, there were no reported hospitalizations that were implicated that implicated the use of the vaccine as a causative agent. Now, some of these studies used surrogate markers such as immune response rate here to assess the efficacy of tetanus vaccine. So this favored tetanus vaccine, and adverse events were also noted in 8 of these in these 8 studies. So as we've mentioned, no studies have focused on the incidence of tetanus as an outcome. However, it's worth noting that no tetanus was reported in patients in combat zones. So these are high-risk zones, even though they have been managed without tetanus immunoglobulin therapy. All-cause mortality, no studies have also reported the incidence of death or mortality as an outcome. And as I've mentioned, no hospitalization has been reported after tetanus immunization. What's interesting to note, or important to note, is that tetanus toxoid-containing vaccines showed a benefit in increasing immune response rates. So what does immune response rate mean? It's defined as having a detectable antibody level against the tetanus antigen 1 month after completing the series. So individuals who were given tetanus vaccines experienced a small but increased risk of grade 3 adverse events at around 2.4%. And these adverse events caused difficulty or impairment in daily activities. Incidence of serious adverse events was estimated at a value of 0.4 to 1.2% among those who were vaccinated. However, the effect estimates in these studies are all based on low certainty evidence due to imprecision of data and risk of bias issues. Grade 3 adverse events in those who were vaccinated, the incidence was at 1.8% among 2,818 individuals, and the quality of evidence for this was moderate. This was due to indirectness related to the use of non-standard definitions of grade 3 adverse events. So the definitions in the studies were different, not really uniform, and estimates came from intervention arms across studies. serious adverse events in those who were vaccinated. Generally, tetanus toxoid containing vaccines were well tolerated. The pooled data from 7 of the studies included more than 3,000 patients, and the estimated incidence of these serious adverse events was at only 0.8%. The certainty of evidence of this was downgraded to low due to the indirectness related to the use of different definitions of serious adverse events, just like what I've mentioned before, across the trials and study design limitations. Right. Now we go to the pregnant population, because in pregnancy, tetanus immunization is a priority. So therefore, there are a lot of pregnant women getting the vaccine. So for the serious adverse events related to pregnancy and neonatal outcome, there was no significant difference between the vaccinated and the non-vaccinated patients. So those who received or did not receive the vaccine, rather, there were no outcomes of maternal or neonatal deaths, no gestational diabetes, no eclampsia, no neonatal hypoxic ischemic encephalopathy, and no failure to thrive or growth deficiencies. Now, for the prevention of neonatal tetanus, the tetanus toxoid efficacy in preventing deaths from neonatal tetanus was actually very good. It was 88%. And this is based on a 2015 systematic review, which included 1 randomized controlled trial assessing the effectiveness of 1, 2, or 3 doses of tetanus diphtheria vaccine administered to women of childbearing age or to pregnant women. So 88%. Remember that. All right. So this is a table summarizing all the critical outcomes of tetanus vaccination in pregnant women. So this is somehow similar to the table I've presented to you before, but there were no studies investigating on the incidence of tetanus, all-cause mortality, hospitalization, and immunogenicity. However, there was a study, 1 randomized controlled trial on the prevention of neonatal tetanus and also the adverse events after immunization. So in pregnant women, basically, the immune response rates data were limited. If we had data on the non-neonatal tetanus, well, in pregnant women, the data is a bit more sparse. No studies were found on the incidence of tetanus, all-cause mortality, and hospitalization as an effect of tetanus vaccines. But the risk of experiencing grade 3 or more serious adverse events was not significantly increased with tetanus immunization. So this is important to note. If you have pregnant patients, this is one thing that we can use to convince them on having tetanus immunization. So the risk of adverse events was not significantly increased. The effect estimates, however, are all based on low certainty evidence due to imprecision and risk of bias issues. So this is a summary of the most common adverse events that happen when you vaccinate a pregnant patient. So during pregnancy, the incidence of solicited adverse events was significantly higher for pain, redness, swelling, and fatigue. And it was also higher for grade 3 unsolicited adverse events across the symptoms: pain, redness, swelling, fatigue, fever, and gastrointestinal symptoms. However, the rest of the unsolicited and grade 3 solicited adverse events were comparable between pregnant women who received the vaccine and did not receive the vaccine. Now, after pregnancy, when these patients were given Tdap post-delivery, the grade 3 solicited adverse event was significantly higher only for pain. The rest were comparable between the two groups, as well as solicited adverse events for pain, redness, swelling, and fatigue. This was a bit higher after pregnancy. The rest were comparable between those who received the vaccine and those who did not receive the vaccine. Right. Now, what about costs? So in our country, cost is always an issue. So there is still insufficient evidence, whether local or international, to conclude cost effectiveness of tetanus vaccination in adults. Cost effectiveness studies mostly focused on related outcomes like pertussis. Actually, pertussis is the most common for these types of studies. But we have found some country-specific data on it. So in Brazil, universal Tdap for adults was found to be not cost-effective, but this is driven by the pertussis outcomes. In the US, when they tried to replace tetanus diphtheria with tetanus diphtheria and acellular pertussis, this was also found to be not cost-effective, which only resulted to higher cost. However, in Pakistan, supplementary immunization was found to be cost-effective than routine DTP and TD. And in Canada, Tdap was found to be cost-effective if the vaccine is acquired for a total of $10 US for the next 10 years. However, this outcome is based on pertussis and not really on tetanus infection. So if we are talking about cost, how much really does tetanus immunization cost? Unit cost of tetanus toxoid vaccine, if you're getting it from a government institution, it ranges from 28 to 108 pesos. If you're getting it from a private institution, roughly at around 400 pesos. So it's up to you to judge if it's affordable or not. All right. So what about equity, acceptability, and feasibility? So the following factors did not influence willingness to be vaccinated with TD among 60 Filipino urban poor women of reproductive ages. So what are these factors? Socioeconomic, age, educational attainment, and occupation. So there was no influence in their willingness to be immunized with tetanus vaccine. But what's interesting, they also found that there was inaccurate or lack of knowledge among the respondents on tetanus vaccination. So probably we have more room for education. Now we go to, I think this is the last part of the lecture. These are the recommendations from other groups focusing on tetanus vaccine. So the first recommending body would be ACIP, or the Advisory Committee on Immunization Practices. So as of 2020, they recommend to administer tetanus vaccine to healthy adults who completed the series, to healthy adults with incomplete or unknown series, and to pregnant women. The strength of these recommendations were, however, not indicated in the manuscript. So for the World Health Organization, there was no recommendation for those with completed series, but for those with incomplete or unknown series, they recommend to administer tetanus vaccine. And in women, if tetanus vaccination is started during adolescence or adulthood, a total of only 5 doses are required to obtain lifelong protection. Conditional recommendation is given if a woman received 6 tetanus toxoid containing vaccines during childhood, or 5 doses if first vaccinated during adolescence or adulthood before reproductive age. So this is just a conditional recommendation. So you administer, however, tetanus vaccine if with incomplete or unknown series. Now, in the Australian population, Australian Immunization Handbook, they recommend to administer tetanus vaccine to healthy adults who completed the series at 10 and 20 years after the primary course. So they recommend boosting at 10 and 20 years after the primary series. They also recommend to administer DTPA to healthy adults with incomplete or unknown series, and administer DTPA as a single dose in each pregnancy, ideally early in the 3rd trimester. The strength of recommendations for these, both for WHO and the Australian Immunization Handbook, was not indicated. Now, we go closer to home. This is the PSMID recommendations. We recommend to administer tetanus vaccine to healthy adults who completed the series if the last vaccination was 10 years ago. For those healthy adults with incomplete or unknown series, vaccination is also recommended. A primary series must include one dose of Tdap if unvaccinated or incompletely vaccinated. There also is a recommendation on pregnancy. So no further vaccination if with 5 doses of vaccine, including 3 primary series and 4th and 5th doses spaced at least 1 year apart. Otherwise, you administer at least 2 doses of tetanus vaccine with an interval of at least 4 weeks between doses, the second dose of which is ideally at least 2 weeks before birth, so before delivery, and the third dose at least 6 months after the first dose. So administer at least 1 dose of TD, tetanus diphtheria, in subsequent pregnancies. PSMID also recommends to administer DTPA to healthy adults with incomplete or unknown series and administer DTPA vaccine as a single dose in each pregnancy, ideally early in the 3rd trimester. Right. So I think that is all of the recommendations combined. But as if you recall, we presented a summary of recommendations early on. These are our references. And with that, I thank you for listening to this lecture.